Grace, where do you want?
Okay, fantastic. Hi, everybody. Welcome to Congenital Heart Academy. We are very happy to have all of you with us today. This is going to be a fantastic webinar. We have great speakers and great panelists. So please follow us on social media and subscribe on our YouTube channel. There you can find this webinar and the other webinars we have done so far. More than 200 webinars are there for free for you guys to watch. And if you find this webinar useful for you, please share the YouTube link with your team afterwards, because then people can watch and enjoy these great speakers. And I'm sure it's going to have a great discussion. So we are going to have 3 speakers today. And by the end, you're going to have questions and answers hosted by Dr. Rima Bader. And we are happy to have as a panelist, Dr. Norman Silverman. So now I'd really like to introduce the team from Lurie Children's Hospital from Chicago. They are going to start this fantastic webinar. Thank you guys so much. And please type your questions on the Q&A chat box.
All right, can everybody hear me and see my screen?
Screen not yet, we can hear you. Oh, but maybe it's me. No, we can see your screen, yes.
Wonderful. Well, thank you so much for the opportunity to get a chance to speak with everyone today and to include me and others of our team as part of your webinar. My name is Teddy Jones. I'm a pediatric and genetic cardiologist at Lurie Children's Hospital in Chicago. And I am also co-medical director of the Connective Tissue Disorder Clinic here. And in addition to that, I run our cardiovascular genetics clinic here. And today I'm going to be talking to you about modern genomic strategies in prenatal congenital heart disease diagnosis. So I don't have any financial disclosures to report. And my agenda today is going to focus on a handful of things. The first is going to be touching on why genetics actually matters at all in fetal congenital heart disease. We'll then talk about what is in our genomic toolkit to be able to use to test fetuses and patients with congenital heart disease, going beyond just the microarray. And then we'll talk about what, who, and when we should be doing that testing. And then I'll try to present that all within a framework of harm reduction and wrap that all around 2 fetal cases that try to illustrate how the timing and modality that you choose for your patients can change the story in the course of their clinical courses. So we'll start with 2 fetal cases of complex congenital heart disease. Case 1 on the left is a fetus with hypoplastic left heart syndrome. The fetus was also identified to have a single umbilical artery when there should be 2, and hypotelorism, or a narrowing between the eyes, both of which is 2 on the is a with transgrade artery. So, you cardiologist, all prenatal screening was normal. How would you counsel each of these families on the value, timing, and potential impact of further genetic testing? Furthermore, what genetic testing modality would you recommend? Now, if you were a very discerning practitioner with a good genetic background understanding, which I hope you will all be at the end of this talk, you might conclude that on the left, case 1, a hypoplast with extracardiac anomalies, the testing yield would be significantly higher and perhaps more valuable than in an apparent isolated case of transposition. And you might be right, but I want you to hold on to that thought until later, as we will return to these 2 cases in more detail. So most genetic counseling usually starts with why testing matters and how often we find an answer when we look. So we know that at least 30% of patients with congenital heart disease will have an identifiable genetic cause. And this is a pie chart that breaks down our best understandings of the etiology of congenital heart disease. Now, I should note that this pie chart is intentionally approximate, but it reflects our best current data from large CHD cohorts like the PCGC. So we know that about a quarter of congenital heart disease is due to chromosomal abnormalities or pathogenic copy number variants, which you see in red. These are large swaths of the genetic code that are deleted or duplicated. So aneuploidy, which is the dark purple slice, is defined as having an extra or missing whole chromosome. So think trisomy 13, 18, or 21, or Turner syndrome, which is monosomy or one copy of the X chromosome. Copy number variants, which are labeled as CNVs in the light purple slice, are small sections of DNA that are deleted or duplicated, and they're smaller in scale than an entire chromosome. And the most common causes we think of here are things like 22q11 deletion syndrome or Williams syndrome, which is caused by a 7q deletion. Another 10 to 15% is due to monogenic or single gene causes. So de novo variants, meaning genetic changes that are new in the patient and not inherited from a parent, represent the largest chunk of that in green, about 9% of all congenital heart disease, while parentally inherited dominant variants and autosomal recessive variants represent smaller but important contributions as well. So we also recognize that a small but real contribution comes from environmental exposures and teratogens. Examples of this include poorly controlled pre-gestational diabetes, maternal PKU, certain medications, or infections such as rubella early in pregnancy. However, the biggest slice is still unknown. Even with state-of-the-art testing, we don't yet have a clear causal diagnosis in more than half of patients. So genetic findings can strongly influence prognosis, management, and long-term outcomes. When you think about the contributions to nearly every outcome we care about, syndromes like trisomy 21 or trisomy 18 come to mind as very obviously and independently affecting the possibility of complications, like respiratory failure, pulmonary hypertension, ventricular or valve dysfunction, neurologic development, somatic growth, and ultimately mortality. However, the more we learn about genetics, the more we can use it to precisely risk stratify. So you can see here on the right, this is a forest plot demonstrating evidence that even non-syndromic variants that affect things like chromatin modification or ciliary development genes can confer a significantly elevated risk of critical outcomes like mortality, cardiac arrest, and prolonged respiratory support after a surgery. And looking not just now, but also into the future, precision medicine and gene-specific therapies are the future of advanced medical management in many fields, particularly within high-stakes worlds like ours in cardiology. And so one example of this that has already been implemented at many centers, including ours, are medications like trametinib, which is a MEK inhibitor that blocks enzymatic pathways that are upregulated in rhapsopathy syndromes like Noonan syndrome. These can be used to specifically treat complicated cardiac phenotypes in a select series of patients. And so we are certainly decades behind certain fields like adult oncology, but ultimately genetics play an increasingly larger role in our own precision therapeutics. And I think tools like this are going to become only more common in our near future. So genetic testing can also uncover risks in family members, which can enable cascade testing and clarify recurrence risk, support reproductive planning, and set families up well for future pregnancies. In general, we say that the most common human birth defect is congenital heart disease, and it affects about 1% of all live births. And if a family already had a child with congenital heart disease, we routinely quote a range of somewhere between 2 to 4% of recurrence risk in future pregnancies. However, in reality, there are large epidemiologic studies that have shown that this recurrence risk ranges much more widely than 2 to 4%. As you can see in this table here, it can vary significantly by lesion type and by the number of family members that are affected. And when you have recurrence, it's not random, it is more often of a concordant morphologic subtype of congenital heart disease. Now, I think that there are two really important things to note about most of these studies that comprise these commonly quoted numbers. And one is that they're derived from ethnically homogeneous studies with a large representation of those from Northern European descent. And the second is that most of these studies are done in the absence of, or were completed, I should say, in the absence of widespread genetic testing. So they largely predate modern genomic testing. So really they're a rough guide rather than a precision estimate. So we already talked a little bit about the large range of genetic differences that can cause congenital heart disease, but to understand how we test for things, I like to consider these genetic changes in terms of their actual physical size and structure. So you can see at the top of this upside down pyramid, changes where anywhere between 200 and 3,000 genes are affected are generally termed aneuploidy, again, where huge swaths of your DNA up to a whole chromosome are affected. The next are CNVs, or copy number variants, and that's when a smaller but still sizable portion of DNA is deleted, duplicated, or rearranged in a way that can affect just 1 to as many as 60 or more genes. And then finally, complex congenital heart disease can come from anywhere from a huge deletion all the way to a single nucleotide change in a single gene, like in the case of many monogenic syndromes like Noonan syndrome, as an example. Now, what tools do we have in our genetics toolkit to actually look for these genetic changes? In other words, when we get a DNA sample, extracted and then amplified in a lab, what tests can we actually run? So this slide summarizes the main tests that you'll see in practice and what each one actually kind of quote unquote sees in the genome. So the first is cell-free DNA, and it's important to know that's a screening test. It looks at placental DNA that's circulating in maternal blood and is used to estimate risks for common trisomies and a few large copy number variants. It's really high performing as a screen for most aneuploidy, but it's not diagnostic and doesn't truly test congenital heart disease genes. The second is a karyotype, and a karyotype is a classic chromosome picture. It's almost more of a radiology study than it is a genetic study. So it only picks up big changes, extra or missing chromosomes or large rearrangements. FISH is the next one. It's a targeted tool. You ask a specific question like, is a 22q11 deletion present? And so it's fast and focused, but it only tells you about that one specific region and not the rest of the genome. And I do note that despite the historic predominance of FISH, there's really only a few select circumstances where they're used in modern genomic testing, at least at our center. And really, they're not often considered fully diagnostic tests, even in those situations. So in the postnatal world, we virtually never use them. And I tell most of my cardiologists and ICU doctors to actually drop it from their vocabulary. The chromosomal microarray, or CMA, or microarray is next, and that's really our recent historical workhorse test. And it looks across the whole genome for microscopic deletions and duplications, and can also cover aneuploidies as well. Now, moving beyond the microarray, panels or gene panels sequence a curated list of genes, for example, congenital heart disease genes or aortopathy genes. And the plus side is that you get high coverage and a tighter, more clinically focused result. But the downside is that you're only seeing what's on that single panel, and you're only seeing what's on that single panel at the time the test was run. So older panels are often significantly incomplete and can't be reanalyzed later. Exome sequencing looks at essentially all coding exons, so it casts a really wide net, which helps in children with congenital heart disease plus other anomalies where the gene may not be obvious. And it mainly finds single nucleotide and small insertion or deletion variants. And then the genome goes further by sequencing almost all of your DNA, including non-coding regions. So it can pick up many copy number variants and structural variants in the same test. And so the power is huge, but the interpretation and practical things like insurance coverage are still catching up. And so I've addended to the end of this table a few tools that are not quite widely available or implemented, but I think are important to know about. The first one is long read sequencing. And long read sequencing does essentially the same thing as a traditional short read genome, but it uses much longer reads of DNA in order to abstract information. And so that makes it better at detecting a lot of things like structural variants or repeat expansions on the same or different chromosomes. And so right now it's used mainly in specialized or research settings, but it's likely to move into clinical pipelines in the somewhat near future. And then RNA sequencing, or RNA-seq, doesn't look at DNA, but rather at RNA. So it tells us about one step farther down the biologic pathway, things like gene expression and gene splicing. So clinically, it's useful to clarify when we have uncertain DNA variants, like showing that a suspected splice site variant actually does cause abnormal splicing in a gene that may cause congenital heart disease. So in terms of the size of the defect, I like this figure going back to it because it shows where the microscope of different, more limited tests, like a karyotype or a microarray that you see at the top, looks compared to, say, gene panels at the bottom. And it also shows how exomes and especially genomes are much more broad and comprehensive tests. However, I think it's even more impactful to think in terms of what percentage of diagnoses you may be missing with certain testing modalities, especially in the modern era. So bringing this back to the pie chart that I shared with you earlier, a karyotype, again, will just be testing primarily for aneuploidy in that dark purple. A microarray will test comprehensively for copy number variants in the light purple, and we'll test for most aneuploidy that may miss some low-level cases of mosaicism. A gene panel will plumb whatever genes you want it to plumb and test whatever genes you want it to test, but it's only as broad as the list of genes that you interrogate. And exome sequencing is able to look at all of those genes in the bottom right-hand corner, but also the testing is getting better and better and able to pick up a fair bit of copy number variants in aneuploidy. And then finally, genome sequencing is able to interrogate all of what we know causes congenital heart disease genetically currently. So now that we've reviewed our toolkit, that sort of brings us to 4 big questions that we have left to answer. And that's, what tests should we send? Who should we be testing? When should we test? And how do we minimize harm? So one of the reasons why this topic deserves such careful discussion is that there are no definitive, universally adopted recommendations for exactly what prenatal test to send and when. So ACOG has an older committee opinion and practice guideline that was published in 2016 that recommends only chromosomal microarrays. And though there are some published guidelines that recommend consideration of more comprehensive exome or genome sequencing as a first or second tier test in fetal congenital heart disease, importantly, many of the major professional societies that we look to currently have no structured specific recommendations for genetic testing modalities in these patients. However, I think there is consensus on several points, and that's that genetic testing should never be sent without appropriate counseling, and it should never be mandatory to care. So if there are no clear national or international guidelines or universally adopted guidelines, how do we decide what to do? Well, if you look across fetal structural anomalies, and specifically congenital heart disease that you see outlined there in red, prenatal exome adds about a 15 to 20% incremental yield beyond traditional testing like a karyotype and a microarray. And emerging data suggests that the genome may add even further, particularly for structural variants. So staying at the microarray level alone in complex fetal congenital heart disease increasingly means that we're knowingly leaving diagnoses on the table. Now, another pertinent question to ask in situations without clear recommendations is who we should be testing and whether there are adjunctive pieces of information that can support when you should test broadly. So one salient example of this is extracardiac anomalies, which we know, as you can see from the figure here, is the single biggest predictor of when we can identify a clinically relevant genetic result. So it raises the testing yield, you can see here, from 7.9% in non-dysmorphic babies with congenital heart disease, all the way to just shy of 50% in dysmorphic babies with clear extracardiac anomalies. So this begs the question, why not just offer expanded testing to those with extracardiac anomalies? And that's actually a pretty common test in many, or common practice, I should say, in many hospital systems. Well, historically, that testing approach was the case, but our approach to genetic testing over the past 10 to 15 years in congenital heart disease has changed a lot. And as you can see in this table, progressing from left to right, as preferred testing modalities have changed, so have genetic testing yields. And though we know that the presence of extracardiac anomaly confers as much as a four-fold increase in the risk of genetic diagnosis, Stephanie Weir's group out of Indiana have shown that if only extracardiac anomalies were to guide testing, up to 13% of patients with isolated congenital heart disease and identifiable genetic causes would have been missed. And if that's true in the postnatal ICU, which is where this study was done, where we have more accurate testing and phenotyping, imagine what we could be missing prenatally. And this really is evidence for why genetic testing should not be driven by extracardiac anomalies alone. Now, another important consideration in testing approach is not just whether we find an answer, but how that information can be used to drive decision making. And in this setting, timing makes a big difference. Genetic diagnoses are critically important because they can improve risk stratification. They can allow anticipation of complications and atypical hospital courses and allow for more realistic discussion of outcomes with families. And I cannot emphasize that last point enough, and that the timing of this knowledge is critical for many of our congenital heart disease patients, namely our single ventricle patients who undergo the first of their three major palliative surgical interventions in the first week of life. So even with our progress in available genetic testing, there are often so many logistical details and delays that without prenatal testing and only postnatal testing, we almost invariably go into that very first surgery especially for our single ventricle patients, which can be sometimes the biggest medical decision-making inflection of a patient's life. And we go into that decision genetically blind. So in addition to asking what test and who to test, a principle that really should anchor this discussion is avoidance of harm. Now, in medicine, there are many definitions of harm, but ultimately encompasses any negative impact that results from healthcare processes, interventions, or errors. And it's really a central tenet of patient safety. Now, prenatal genetic testing itself presents some unique challenges, and there are several in particular that pose the potential for introducing harm, most of which we've already touched on. So the first is timing. So genetic results obtained prenatally, like we talked about earlier, can reshape our understanding of perioperative and extracardiac risks before those critical interventions in the first few weeks of life. And postnatal testing, by contrast, can delay results by days to even weeks after birth. Procedural risk is probably the most obvious challenge that comes with prenatal testing because currently it requires invasive procedures like amniocentesis or chorionic villus sampling. And for many families, the immediate and tangible risks of that needle may outweigh the potential benefits of that information. Third, before birth, we can't reliably detect many extracardiac anomalies. Our phenotype is really inherently incomplete. And this also limits how confidently we can interpret genetic testing results and sometimes risks either misclassification or overinterpretation of genetic results, even if we find them. And finally, present in all of these are the conflicting priorities that many parents can face in all of their fetal health touchpoints. A family hears from their fetal cardiologist how important it is for their pregnancy to make it to term, but it may be in the next visit they're told how the risk of preterm birth that can come with an amniocentesis. A family hears about how genetic testing results may improve risk management, but they may be worried that genetic testing could find a diagnosis that itself makes surgery too risky. So each of these challenges illustrates the balance we have to strike. Testing can prevent harm by clarifying risk and guiding care, but it can also introduce harm if it's pursued indiscriminately. So how do we strike that balance? Well, ultimately, I see counseling and institutional alignment as the filter that can take genetic testing and turn it into harm reduction. Now, families facing a prenatal congenital heart disease diagnosis are navigating profound uncertainty, and so thoughtful genetic counseling prevents harm by clarifying prognosis, preventing misinformed choices, identifying family risks, and setting expectations when things get complex. Whereas equitable and effective use of genetics in management requires institutional alignment. Everybody from genetic counselors to obstetricians, cardiologists to ICU providers, and surgeons all have to be on the same page, and because only through that alignment can results be meaningfully acted on by the whole team. So a more concise way of thinking about this is that effective counseling helps families decide when benefits outweigh risks, while institutional alignment helps care teams decide when benefits outweigh risks. So the message you should really take home from this isn't send genomes on everybody. It's that going beyond that proverbial microarray only makes sense when we match the right test at the right time to the right family, with counseling and institutional alignment as sort of our harm reduction tools to be able to effectively do that. So let's return to our two cases. So the first, with hypoplastic left heart syndrome and extracardiac anomalies, underwent prenatal genetic testing by amniocentesis, which revealed an 11q23 deletion that was consistent with Jacobson syndrome. This allowed for extensive prenatal counseling, not only about the diagnosis itself, but also about how it could affect prognosis in the setting of single ventricle disease. Postnatally, the patient was able to receive multiple targeted consults within the first few days of life, identifying Jacobson-associated complications like significant platelet dysfunction, lymphopenia, hypoglycemia, all of which could be done prior to a potential surgical intervention. The second case, with transposition of the great arteries and a VSD, ultimately had testing deferred until after birth. A CMA was drawn on day of life 1, but ultimately returned non-diagnostic, but not until day of life 14. And so afterwards, a trio exome sequencing was pursued, but coordination took several days. And finally, at nearly a month of life, a diagnosis of Church syndrome was made. So this delay postponed the recognition of critical secondary features, including retinal colobomas that can confer risk of blindness and airway anomalies, and clouded the high risks of morbidity that this child could encounter postnatally. Now, I want to really emphasize that both of these patients received standard of care. And this just illustrates how difficult it can be to weigh the balance of timing and procedural risks with an incomplete phenotype. However, I think it does emphasize how helpful early, broad genetic testing can be when it's performed judiciously, and how it can help clarify risks for families and care teams. And so the takeaways really from this talk that I hope you leave with are that the first is that at least 30%, if not more, of congenital heart disease is genetic, and that the microarray alone is a growing fraction of diagnosable disease. That in complex heart disease, extracardiac anomalies can be, but relying on them alone will miss a meaningful subset of high-risk diagnoses. And finally, the combination of the right test at the right time and with the right counseling and care team is the things that can turn genomics from more data into better decisions for families. So thank you so much, and I'm looking forward to discussing this later.
Thank you so much, Edward. I'm sorry I was late, but I'm on call, so I just want to welcome your presence. And I think
definitely gonna that.
I came in the right time. And I just wanted to welcome everybody as well, but it's a very important, everything has to be right? Right diagnosis, right timing, right test, right counseling, right outcome, right? Now, I wanted to ask you, because I face this quite a lot. Sometimes parents don't want to know.
Yeah.
So
Yeah,
I had just 2 days ago. I mean, the question is that apart from the cost, because now we're talking the whole world, and in the States there's coverage, there's another in Europe, but some other countries like the Middle East and Far East, I'm not sure where as well, and North Africa, this is not a clear cut. Now, they would always say, why should I know? What difference will it make? Of course, as physicians, we know. How do you simple to them?
Yeah, I think that that's such a good question, and it's a really difficult one that we encounter all the time. So I think the first part of that is that it is the parent's right to not know. Genetic testing can be an enormously effective tool, but an important thing to know that is not mandatory. When I talk to families about this, the first thing I acknowledge is that genetic testing is an enormously personal venture, especially when we are doing things like trio testing, where we're testing families, include not just a patient, but also their parents. And so for me, I think starting with the acknowledgement that it's a very personal thing and that they can say no is important. But I think the best thing that you can do to provide good counseling to a families is to lay out on the table how it can actually be helpful. I find that when I have the highest of convincing a family the value of genetic testing is talking about how we actually use that genetic testing. It's not just used as a diagnosis, but it's used to maximize the outcomes and maximize the trajectories that we can provide to patients. And so I think when you focus on it as a tool to be able to maximize and optimize the care that you're providing to families, I think that's really where you relay the power of genetic testing, and you can provide families with better understanding of what decision they're actually making.
Like your CHAR syndrome, this is a crucial example. It took a month to know that. So I always tell them it's a story. You want to know more about your baby. You want to know the outcome. You want to know the prognosis. You want to know the steps. Is he going to walk? Is he going to? And I always make it that simple that I always call it the shock stage prenatally. I want to break the news, and then and so we're together till before delivery. Now I wanted Sheetal, do you have an advice? What do you tell your patient?
Yeah, no. So thank you. Thank you for this opportunity, first of all. As Teddy mentioned, in our center, we have our workflow that every single CHD parents are going to have the genetic counseling from our counselors and offer that if they're interested, then we are happy to do the genetic counsel. And then we also go into how it would be helpful. And then we leave it up to them. I think that leaving up to them is really, really important because it's a very personal decision. I also sometimes, if I think that as a caretaker, that information would be helpful, sometimes it's more important, sometimes it's not so more important. But if we think that there is a lesion that we should know, then I would also give examples of how we were able to provide better care, like this Jacobson syndrome baby. We were able to provide counseling, but also do all the other organ testing, platelet function, everything. And that would improve the outcome rather than going blind, not knowing about Jacobson syndrome and just doing our standard approach of Norwood. So I think that it is really important, but it is at the end of the day, it is very personal choice. So we lay it out, we let them think, and we let them decide.
But by the way, the surgeons need to know. He's not going to take the baby for Norwood or single ventricle without, this is a prerequisite for surgery, I think. Most of them ask for that, don't they?
At our center, we haven't made that strong that we would not offer Norwood unless we have the genetic testing. We have still, but there are certain conditions that we do wait for at least some genetic testing, and Teddy and his team works really well to expedite the results. And those are the babies who have single ventricle, along with other things that we are highly suspecting genetic syndrome. And then the harm is that sometimes with genetic syndrome, you take the baby to Norwood and that Norwood can be harmful. So it's not the right thing for the baby. And so sometimes we have delayed while we are waiting for the test result. But if the phenotype looks otherwise normal, we have proceeded with Norwood because we want to do Norwood in timely fashion. Many of these genetic testing results are not back.
Well, now I wanted to ask both of you and Teddy and you. Shane Morris was with us, and she said she doesn't like the NIPT at all prenatally. And I've noticed that you went into amniocentesis immediately, and your whatever I quote. Do you believe in NIPT? Do you do the short or the extended, or you don't believe in it at all? You go with amnio?
So it's funny that you quote Shane Morris. Dr. Morris, or Shane, I should say, is a personal mentor of mine. I actually did all of my training with her, including in cardiovascular genetics. So I know her thoughts very well. I think the important thing to know about NIPT is that it's non-diagnostic. So it certainly has a value, and I think it certainly has a value in terms of the things that you can tell a family before you do diagnostic testing, what is likely and unlikely to be able to find. But the important thing to know is that NIPT does not give you an answer. You know, one example is for Turner syndrome. Whenever the sensitivity and specificity of say, cell-free DNA is very good for a handful of aneuploidies. But when it comes to Turner syndrome, if you have a positive diagnosis, or I should say a positive screen for Turner syndrome on cell-free DNA, only 40 to 50% of those people actually end up having Turner syndrome. So it's not a diagnostic test. It always has to be followed up. And so I think that sometimes creates confusions with families, which is why one of the parts or cogs in the system that is probably the most important, I would argue, as a cardiologist, is actually our genetics. They do such an incredible job and have the time to be able to go in and talk to families. And there's some families that they're meeting with where both parents are a PhD, and there's other parents where they're meeting with that this is the first time a parent has ever even. And so I think being able to relay what those tests actually mean to a family and allow them to be able to make those next decisions is a really important aspect of that. And so you just have to acknowledge what the limitations of those tests are.
But yet, for our MFM colleagues, they always say it's a screening test. They like it.
Yeah.
They do it, and it's a screening test. And then if it's positive, they go for amnio. But there is extended one. I think the original one covers 3 or 4 and the sex, but the extended one covers what does it cover? Does it cover the 22q and others?
Yes, it will cover 22q and a handful of others. Yes, but for us, ultimately, even still, that represents a non-diagnostic study. So I think when you're dealing with the average pregnancy that's going about, that's, I think, a helpful test. But when you're talking about complex congenital heart disease, chances of finding something are so high, and the chances of finding something that's not covered by those cell-free DNA tests is also really high. So I think sometimes people have a reason for not liking cell-free DNA because sometimes it can provide some false reassurance that there could be a genetic etiology that's helpful to know early. And so I'd imagine that can be a drawback for many people, but I still find a lot of value in many of our families' lives.
If it was a rhabdomyoma, what would you tell them?
So rhabdomyomas, I think one of the things you have to worry about is tuberous sclerosis, and so that would be when you're approaching a very isolated lesion like that, knowing what things you're looking for is really important. So that you can be a little bit more targeted about what other things extra cardiac wise you're looking for, and that can help with the genetic counseling that you're going to give to the family.
But is it a mutation or some dominant? Because I had a case and a couple wanted to separate. So what would you tell them in the pattern of inheritance in this case?
Oh, goodness. Well, it usually, I think that the thing that's actually a really good example because it pulls back and it shows how personal genetic testing can be. So one of the slides that I went through on earlier in the talk was to show how often we find de novo mutations in families and de novo mutations in patients. And so very oftentimes I find, like in a case like this, that when you have a genetic test and shows that it's not from either parent, but it's a brand new thing in baby, that can be very relieving for families and for patients. There's a lot of the times when we do a genetic test and it provides relief to a parent because they felt like it was their fault. And so in a case like that, I think that provides even more and more helpful of a reason to be able to proceed with genetic testing, because it can very often provide an answer that it's not a parent's fault, and that this is just an unfortunate genetic event that happened in a single child.
So de novo mutation means that the recurrence risk is minimal?
It is lower than what we would than if it were to be an inherited gene. Yes, it's hard to know. We don't find an answer. We still know that recurrence risks are higher than the general population. So that's a difficult question to answer, but I think it can be helpful in terms of being able to say you're probably on the lower end of that recurrence risk spectrum if your testing is negative.
Thank you so much. And Norm, do you have any questions? I'm sure. I'm not sure if you're still with us, but
Yeah, I'm still here. The one issue I would just like to consider is you've talked about the genetic testing in the patient, but what about in the family? How does that come into your play?
Yeah, it's such a great question. And so there are certain tests where we will always try to obtain parental samples in. And those really are those broad spectrum tests like an exome sequence or a genome sequence. And that's right at the kind of the front end of things. And the reason why we won't necessarily do parental testing at the front end of things is because when you test 20,000 genes and you find an answer, sometimes you don't know if that answer is really truly pathogenic or not. So you can look in the parents and looking to see if this was paternally inherited or not, and if that parent is also affected, can be helpful in adjudicating whether or not that genetic variant that you find is actually your answer, or whether or not it's just noise, right? That's just normal genetic variation. That's on the end of things. On the back end of things, testing families can be really helpful when you do find an answer and you're looking backwards. So let's say we find a genetic and genetically confirm a diagnosis of 22q in an infant or in a fetus. There are cases where that can come from a parent. And so what we'll do when we find an answer in someone is we'll go and do what's called cascade testing or cascade screening, where we'll look and we'll start just in first degree relatives and the parents. And if we find that one of those parents is where that genetic test comes from, or that genetic finding comes from, then we can expand within the family and see how far back or forward does that genetic change actually track. And that's why genetic testing is not just helpful for the patient. Sometimes we can find a genetic change that finds a syndrome that runs in a family, and we can help with the health management of an entire family.
Also, I think the long QT syndrome, this is when if you find it in a fetus, then you go for it, definitely for the...
Exactly. Right? Cardiomyopathies, long QTs, and even some genetic, in many monogenic diseases, a broad spectrum of what it looks like in patients. And you can have things like variable expressivity and variable penetrance, where some people will have a genetic change and not have any features at all, and other people will have very severe phenotypes. So just because you look at a parent and they don't look like they don't look like they're affected, doesn't mean that this is automatically a
Thank you so much. There is a question here. Do you test cases with small muscular VSDs or normal variants like PLSVC?
Oh, that's a great question. Okay, so that's sort of a hot topic within the field of congenital heart disease testing. My approach is that I look at what the value is to the family. So for most muscular VSDs, most small secundum ASDs, I won't necessarily consider genetic testing unless there is a second hit, right? There is something there is a case of multiple cases of VSDs or multiple cases of congenital heart disease within a family. Or yes, you may only have a small muscular VSD, but you have significant developmental delays, or you have a solitary kidney. If having a second hit is really what pushes me over the edge to think, oh, we should really consider genetic testing, or if there's a really strong family push towards wanting to do genetic testing for other legitimate reasons. There are some variants that we consider to be very common that sometimes there can be value in doing genetic testing. One example are like right aortic arches. that definitely is a reasonably common variant, but there's a increased enrichment of a genetic disease like 22 in those with right aortic arches. So especially in those that have right aortic arches and a vascular ring, we will certainly consider genetic testing. And then I think the final thing to consider is, again, what are you going to do with it? If you have a congenital heart disease, no matter what it is, if you're going to be undergoing surgery for it, there is value in doing genetic testing, because if you find an answer for it that gives you other perioperative risks, you can address those perioperative risks going into the surgery. So I think that those are sort of the guiding principles for what I think about genetic testing when it's not obviously hypoplast or something on the more severe list.
And the left SVC?
The left SCBC, again, I think if it's just isolated and there's nothing else, then I think that sometimes you can hold off. But I think if you see a left SCBC, you should think, could there be other signs of heterotaxy? Could there be abdominal situs issues? And so sometimes that warrants consideration of other investigations. If you find other things there, then certainly you can consider genetic testing.
Sheetal, do you agree that not all congenital heart diseases will be tested genetically in utero? I certainly don't agree. I think all of them should have the genetic testing if the resources are there. But I'm not, of course, the risk of invasive or non-invasive. But
and I should say, a lot of these questions, I'm not a fetal cardiologist, so I've been answering a lot of these questions for the postnatal world. The prenatal world is much harder. Your phenotype is incomplete. So I actually, for most of those, I would say genetic testing would be important, simply because, and I agree with you in that regard, simply because you don't know what you're missing when it comes to your prenatal extracardiac phenotype.
But the question is the muscular VSD. That's really, we see quite a lot. And that's, my ex-mentor, Dr. Huta, used to teach me saying any VSD should have genetic testing. But in real life, I didn't find this really cost effective. I'm not sure what Sheetal would say, and Dr. Silverman as well.
Yeah, I think prenatally, the risk of genetic tests, we also need to consider the risk associated with the amniocentesis. And postnatally, it's a blood test. So I think prenatally, we do have to consider that. And for many families, that risk is not acceptable risk for muscular VSD when there is, we do not anticipate surgical intervention for the VSD. I view these findings as a window into looking more about what else is happening with the baby. And then the left SBC finding can then lead us to look more, and sometimes we find heterotaxy findings, and then we talk about, because for families it is important. So I view at these non-surgical thing as a window of opportunity to see what else is happening, and then consider genetic test. I do think that the risk profile is a little bit different, because amniocentesis has gotten super safe, but it's at the end of the day, it's still invasive test. So we do need to consider that risk-benefit assessment prenatally.
Thank you so much. And I think we should move to our next speaker. And it's my pleasure, of course, and honor to present Dr. Sheetal Patel. Of course, is a consultant fetal and pediatric cardiologist, director of the Fetal Cardiac Program, co-director of Chicago Institute for Fetal Health in Ann Robert and Children's Hospital of Chicago. And he's going to talk about decoding in transposition, d-TGA. Thank you so much, the prenatal clues, a very important topic. Thank you.
Yeah, thank you very much for this opportunity. Can you guys hear me okay and see my slides?
Yes, yes, yes. But put it on the show mode. Yes, thank you.
Okay, wonderful. So thank you again for this wonderful opportunity. So nice to meet with you all. I love d-TGA. So thank you for this topic as well, of unlocking some prenatal clues, delivery planning, and then outcome discussion on d-TGA. So just few disclosure, but none of the disclosures are relevant to today's topic. Today, I want to discuss some key fetal echo findings for d-TGA. We then want to review the delivery planning and resource preparation, which is super important. And then we also want to discuss some anticipated outcomes so that we can counsel the families about what to expect. So just looking at the anatomic features of d-TGA, we all know that a d-TGA results because of ventricular arterial discordance, because the right ventricle gives rise to aorta, then the left ventricle is giving rise to pulmonary artery. In many cases, we would see a subaortic conus, and then also mitral to pulmonary continuity, fibrous continuity. 50% of those cases with d-TGA would have intact ventricular septum, where there are no other associated cardiac defects other than a PDA and a PFO. So that is the more typical of a d-TGA with intact ventricular septum. If we look at the fetal echocardiographic features, this is how it looks, where here is a fetal echocardiogram. This is posterior, this is anterior. This is the left ventricle, and you know that's a left ventricle by the smooth surface of the interventricular septum. As you look at what comes out of the left ventricle, this great artery that is coming from the left ventricle is bifurcating, indicating it's a pulmonary artery. And then the right ventricle is giving rise to the aorta, which is more rightward than the pulmonary artery. And we will have more examples of that. The physiologic aspects of d-TGA is super interesting to me. So in a typical heart, we would have a circulation in CDs where the deoxygenated blood goes to the lung, gets oxygenated, comes back to the left side and out to the body. However, in d-TGA, the circulation is more in parallel to each other, because the systemic venous return comes to the right ventricle and then goes back to the aorta, so goes to the systemic circulation. And pulmonary circulation is bringing the oxygenated blood back to the left ventricle, but then goes back to the pulmonary. So because of this circulation parallel to each other, the initial survival is heavily dependent on a good mixing of this blue and red blood at the atrial level. And also we can have some help with the PDA, but the circulation of d-TGA also predisposes to a few other things, which are interesting. So what happens in a d-TGA is that the PDA throughout the pregnancy is experiencing higher oxygen saturation than what a four-chamber anatomy would do, because it is seeing the red blood. So because of that, there could be premature ductal constriction, because we know that the PDA, the ductus arteriosus, gets very sensitive to oxygen saturation later in gestation. So if this duct starts constricting, what will happen is that the blood flow will increase to the pulmonary arteries, and then there will be increased pulmonary venous return, increasing left atrial pressure, and that can start pushing the flap of foramen in utero, creating the finding of restrictive atrial septum even before the baby is born. So I think it's super interesting how these physiologic changes predisposes the d-TGA babies to have restrictive atrial septum. And the second thing that is important is that this premature ductal constriction is also probably the reason why we see higher risk of pulmonary hypertension in d-TGA neonates. So with that in mind, just in general, d-TGA happens 2.5 per 1,000 live births. So it's not that common in general, but that's the prevalence that we see. There's a little bit of male predominance. We don't know of any single gene abnormalities, but we have more data emerging, as Dr. Jones reviewed, that if we look more, we might be able to find more laterality gene defects in this d-TGA. We always want to have a checklist of what we are supposed to do as a prenatal fetal cardiologist when we have the diagnosis of d-TGA. So our goals of prenatal management include that we want to have accurate diagnosis. We also want to look for associated cardiac abnormalities so that we can put the full picture together. We want to look for extra cardiac and chromosomal anomalies, because as we just reviewed, that it can affect the outcomes. We then want to sit down and have very accurate and good counseling for the family so that we can prepare them. The management of such complex congenital heart defect is always multidisciplinary. It's a team sport. It's never a single person doing it all. A typical team for this would include fetal cardiology, neonatology, MFM, CV surgery, because they are the one taking care of the babies. We also inform the cardiac cath team for possible balloon-atrial septostomy, ICU, and then pediatric cardiac anesthesia. So it is definitely a multidisciplinary collaborative approach in managing these babies. We also always want to have a checklist when we go in to do fetal echo, because checklist will make sure that you get everything that you need so that you can form your assessment for this baby. When we are scanning a baby, we want to have understanding of relationship of great arteries, also relative size of the great artery. If one is too big than the other, that will be a problem in doing the surgical management. Is there a VSD? Because we will review how having a VSD changes the outcome and approach. Is there malalignment of coronal septum? Because malaligned coronal septum will then can predispose this heart to have outflow tract obstruction. Are there semilunar valve abnormalities? What about the ductus arteriosus? A small ductus arteriosus, a bidirectional shunt can tell us that this baby is at risk for atrial septal restriction. We want to look at the atrial septal communication to see how big it is. And sometimes we miss this last point, but we need to make sure we demonstrate IVC connection to the right atrium, because that is the exit for balloon atrial septostomy, and we don't want to have interrupted IVC, which we have seen in some of our cases. And it is really important to note that, and your cath colleagues would thank you for that. All right, let's look at some examples. A 4-chamber view can be very deceiving. Even though there's a d-TGA, look how normal this is our here on top of the pulmonary and then go ventricle. So there is the atria and ventricle connections are all appropriate. But as soon as you do a sweep, and that's why sweep is super important in fetal echocardiography, as soon as you sweep from posterior to anterior, you see that the left ventricle is giving rise to a blood vessel that bifurcates, which then indicates that this left ventricle is giving rise to the pulmonary. The right ventricle is giving rise to the aorta, arriving to the diagnosis of D-transposition of great arteries. Once we know that it's d-TGA, we want to dive deeper to see like, oh, is that a d-TGA? Let me look further. Here's the left ventricle. Here are the great arteries. See how they are parallel to each other? We should never be able to see both great arteries so clearly and so parallel to each other. We shouldn't be able to see the semilunar valves in a similar orientation, because there's always, in normal 4-chamber heart, there's always offset, so that when you are looking at one outflow tract in long axis, the other one looks at short axis, because they're supposed to cross. These great arteries are not crossing. So that also confirms that it's a d-TGA. You put a color Doppler, you look at if there's a VSD in the outflow region, because that's where most of the VSDs live in a d-TGA. So am I seeing a break in this interventricular septum? Is there a flow going across? What about these semilunar valves? Is there any leakage? Is there any turbulence? Because these two valves are really important, especially the pulmonary valve, because the pulmonary valve is going to assume the role of neo-aortic valve after we do surgery. So it is really important to check the health of this pulmonary valve, which is going to become neo-aortic valve after surgery. A short axis view can also be helpful, because you can see that at some point in this sweep, we saw the semilunar valves both en face. So that also indicates that these great artery relationship is not normal. Also, this view can also help us determine what's anterior, what's posterior, what's right, and what's left when we are determining the position of these semilunar valves. Here's another example. Here are the great arteries that are parallel to each other: anterior aorta, posterior pulmonary arteries, which is bifurcating and giving rise to the branch pulmonary arteries. Here is the ductus arteriosus. Look how small the ductus arteriosus is in comparison to the pulmonary artery. Usually, in typical anatomy, the ductus arteriosus would be as big or even bigger as compared to the pulmonary artery. A small ductus arteriosus can be a sign that this baby is at risk for restrictive atrial septum, and we'll talk more about that. Here is a color Doppler, forward flow in the aorta, forward flow in the pulmonary artery, but bidirectional flow across the ductus arteriosus. Again, that is another risk factor for possible atrial septal restriction. Here is a short axis view that we were talking about. Let me orient you. This is the spine, so this is posterior of the baby. This is anterior of the baby. This is the left side, and this is the right side. As you look at the aortic valve here, and pulmonary valve here, you see that the aorta or aortic valve sits more anterior and rightward as compared to the pulmonary valve and pulmonary artery that is sitting more leftward and posterior. And this locks in our diagnosis of detransposition of great arteries. The three vessel view is super important. Our MFM colleagues love the three vessel view. There are ways to find out that, okay, something is wrong with this heart because three vessel view look abnormal. In d-TGA, many times you would struggle to see all three vessels in your same view. The three vessel view would become like kind of more like a two vessel view. And that is because the great arteries are parallel to each other. They're on top of each other. So you will not see both in the same plane. So as this sweep, you will see pulmonary artery and then the aorta, but you cannot see both in the same view, can you? You are seeing a SVC over here, but then at some point you would only see either aorta or pulmonary artery. And that's what sometimes alerts of somebody that, oh, something is wrong about this three vessel view. Many times we call it an I sign. The I sign is because we are seeing the transverse aortic arch and we are seeing the SVC, but the pulmonary artery is nowhere to be found in this three vessel view because the pulmonary artery lives right underneath this aortic arch. And because it is more inferior, it is out of your picture. So that is the three vessel view in the cases of d-TGA. All right, next, once you know that it's d-TGA, then you go hunt for other intracardiac things. You want to look for VSD because it's present in approximately 50% of d-TGA patients. Outlet type is more common than muscular. If the VSD is posterior malalignment type, then it can have subpulmonic obstruction because the conal tissue is going to push in the left ventricle outflow tract, and that can so the subpulmonic obstruction and then overriding aorta. And then if it's anterior malalignment, it's going to cause the obstruction underneath the aortic valve, and that can be associated with the coarctation of aorta. So look for VSD. Once you find VSD, look for the conal malalignment. Here are some examples. Here is more short axis view. As you start sweeping from more four-chamber view, you find a VSD or a break in the interventricular septum right in the conal space. Another example, VSD is more in the four-chamber view, but also the VSD is not as close to the AV valve. So I would call it inlet type muscular VSD. Here is by 2D and here is by color Doppler. This is another example of a d-TGA case where there was a larger muscular VSD, and this was a VSD is also kind of a mid-cavitary level, large muscular VSD in the case of d-TGA. Now, we talked about the outflow tract obstruction. Left ventricle outflow tract obstruction is more common than the RVOT. Here is one example. This is not the greatest resolution, but that's life. That's what we get in fetal life. We get what we get, the resolution, depending on the body habitus, right? So here is the left ventricle. Here's the pulmonary artery. You know it's a pulmonary artery by the bifurcation. Here's the pulmonary valve, and right underneath the pulmonary valve, you see this tissue that is causing narrowing and crowding under the pulmonary valve, causing left ventricle outflow tract obstruction. Here is another example of a case where there is a VSD that extends all the way from inlet septum to the outlet septum, but by the time you come to the pulmonary artery, there is tissue and crowding underneath that pulmonary valve, causing subpulmonary obstruction. There are always variations. So it is always important to look for what else is going on. for this particular baby, we saw this little bit of a mitral regurgitation in this case, and we were like, why is this mitral valve leaking? And then on further interrogation, when we did a short axis view of mitral valve, sure enough, we found a double orifice mitral valve. So let me orient you. Here is the left ventricle. This is en face view of the mitral valve. This is orifice number 1, the main one, and then there is a second mitral valve orifice, which makes our diagnosis of double orifice mitral valve in a case of d-TGA. It's rare, but it can happen. Then we will go and evaluate the ductus arteriosus. A bidirectional flow in the ductus arteriosus is important thing to recognize because that is known to be one of the risk factor indicating for the restrictive atrial septum. You can see it by color Doppler. You can put a pulse wave Doppler and then show that it is truly bidirectional shunt. Next, RVOT obstruction is, as I said, less common, but it could be more often dynamic. So important to look at the blood flow through the right ventricle outflow. Many times it is caused by anterior malalignment of the septum, often associated with the aortic arch hypoplasia and coarctation of aorta. All right, now once we know the diagnosis, now we want to go and predict if this baby's atrial septum is widely open or it is going to be a problem needing a balloon atrial septostomy. So there are a couple of different features of interatrial septum that can indicate that this baby is at a high risk for restrictive atrial septum. Here is first one. When you see the flap of foramen valve that goes in both atria, see how it goes in the left atria and right atria? This is example of hypermobile atrial septal flap. A hypermobile atrial septal flap, when it goes in both atria, is a risk factor. You could measure the size of foramen ovale with the entire total atrial septal length ratio, and a smaller, if this is 1/3 or smaller, then that may be a problem. When you look at the flow pattern across the atrial septum, you see this red and blue. A bidirectional flow across the atrial septum is also a risk factor. You can look at how mobile this atrial flap is. The atrial flap should be freely mobile. If it is more stuck and if it is angle is less than 30, that means it's not able to open up as well, then that is a risk factor. So those are the risk factors at the atrial level. Then there are risk factors at the ductal level. A small duct less than 3 millimeter after 36 weeks is a risk. Bidirectional shunt across the ductus arteriosus. And third thing is restrictive ductus with pulsatility index less than 1.8. So 3 things: small duct, bidirectional flow, and restrictive flow. Those 3 are indicators of the high risk for needing balloon atrial septostomy. And lastly, the third thing is pulmonary vein peak systolic velocity. So we're looking at the pulmonary vein. We are doing the pulse wave Doppler. We are measuring the peak systolic velocity. If it's more than 41 centimeter, then that is also associated with high risk. Now, the problem with these findings are that here is a meta-analysis that put all of the studies in a calculator to see, okay, what is helpful? You will see that these first 2 lines are restrictive foramen ovale and hypermobile atrial septum. Those are the atrial septal level findings. You will see that the specificity of these findings are high. 90% specificity. That means that if you have these findings, you need to be ready for balloon atrial septostomy. However, look at the sensitivity. It does not pick up all the babies who are going to need balloon atrial septostomy. So poor sensitivity, that means you cannot put your guards down. You cannot be too relaxed or take it false negative that, oh, everything looks fine. Similar thing with ductus arteriosus. These 2 are ductal finding. Reverse flowing ductus arteriosus and abnormal ductal size. Very high specificity, 95% and 97%, but look how poor the sensitivity is. And similar thing with the pulmonary veins also. So what we learn from these meta-analysis is that when we have features of restrictive atrial septum, then they are helpful because they're positive findings, but do not get false reassurance by negative findings. Would maternal hyperoxia testing help? So maternal hyperoxia testing is giving 10 minutes of 100% FiO2 to mom to mimic what happens in a baby after baby is born. So you could do the baseline fetal echo, you can give the oxygen, then you can reassess these findings at the atrial septum, at the ductus arteriosus, and at the pulmonary vein to see sometimes it improves the assessment or your accuracy of prediction. But we're not there yet to still be reassured because these things are not highly sensitive. Although they're very specific. There is, the Fetal Heart Society did come up with an MHO consensus opinion and included d-TGA and provided some features or guidelines for if anybody wants to use the MHO as for improving the prediction as an adjunct to the fetal echocardiography. All right, so that was our assessment, prenatal assessment of the d-TGA. I want to now dive into the delivery planning, which is super important. So where are you going to deliver these babies? All d-TGA need to deliver at the tertiary care center with expertise needed to stabilize the newborn and have a plan for balloon atrial septostomy if needed. Why I say that? Because we don't have a sensitive marker that will rule out need for balloon atrial septostomy. So if you cannot rule out with 100% certainty that this baby is not going to need balloon, then you better be ready. And that's why the location of delivery is really important. Mode of delivery. The mode of delivery, I do have to say that based on our benchmarking survey and what we know, at least in Northern American centers, there is variability in practice, center to center, about how these babies are being delivered. However, I think I like this particular paper that was just recently published by Gomez et al. That compare babies who were born with induced vaginal delivery versus C-section, and there was no difference in what the outcomes of those two mode of delivery. As long as you have communication pathways, as long as your cath team is aware and available, they had similar surgical outcomes and no clear benefit of achieving strict daytime delivery. So I think what I'm trying to say is that it all comes down to preparedness and what resources you have. So this decision is going to be center specific, but it is achievable to do d-TGA delivery without C-section as long as you have the resource planned and prepared. What are you going to need in the delivery room to support these babies? This beautiful study by Thomas et al., this is from CHOP, they looked at their d-TGA babies to see what do they need in the delivery room. So these dots are normal 4-chamber anatomy physiology. By 10 minutes of life, they all mostly achieve 95% of oxygen saturation if you have normal cardiac anatomy. As compared to that, when you look at the d-TGA, they start out very low saturation, and within 10 minutes, their average saturation is 75%. So we know that these babies are going to have hypoxia. Now our job is to determine how hypoxic they are and what we need to provide to them. In that same study, when they looked at what these babies needed, most of them needed at least FiO2 or oxygen above 21% to improve the saturation because we worry about their brain getting enough oxygen. Half of them needed CPAP, and about 1/3 needed positive pressure ventilation. Ultimately, if you look at like all the respiratory support that was provided, half of them ended up getting intubated by the time they came out of the delivery room. So what this slide tells us is that we need to be ready to have resources to be able to provide all levels of respiratory support for these babies. Delivery plan should be also center specific because, as I said, it's very particular to each center what resources you can bring in the delivery room. But there are some guiding principles. All babies or delivery plans should include availability of prostaglandin. We should start PGE because at least it keeps the duct open until we figure out what's happening to this atrial septum. We should always have pulse ox check as soon as the baby comes out and we are ready to put the pulse ox probe in. Check if you can do both upper and lower, put 2 pulse ox. But if you only have one in the resource limited setting, put it on the hand because you want to see the pulse ox that is going to baby's brain. Give oxygen. I know that many of the NICU attendings would worry about giving oxygen to the newborn babies with the heart condition, but this particular TGA baby, it is really important to preserve the oxygenation to the brain because some of these babies are going to be extremely they're hypoxic. So give oxygen if you need to. Communicate. Let your CICU and CAT team know that the baby is born and what is happening and how the baby is behaving. Now, I could think of 2 different ways of triaging. Let's say you did the pulse ox at 10 minutes and your pulse ox is 85%, 87%. You can take a breather. You can relax a little bit to say, okay, this baby is not super cyanotic. So we are going to put UAUV line. We are going to allow some maternal bonding, and then we're going to transfer to cardiac center. But we don't need to panic. We don't need to rush. However, if the pulse ox is less than 75%, then you're like, okay, we have d-TGA with more hypoxia. So we're going to do our plan B. Now, this plan B can look very different at each center. So I'm just going to say what we do at Lurie. For very hypoxic baby, like let's say pulse ox is 50%, 60%, we would intubate and we would do mechanical ventilation because we want to preserve the work that this baby needs to do so that each droplet of oxygen can go to baby's brain. We would do we do not do the balloon atrial septicemia in delivery room. So we would promptly transfer the baby across the bridge to our cardiac center, and we would do bedside balloon atrial septicemia. From our data, we have known that we are able to transfer the baby from time of delivery to entry into ICU within 30 minutes or so. And then our average birth to balloon time hovers around 100 minutes after birth. So we know that the way our resources work, we are right next to our maternal hospital, and that's why it goes really fast. So we don't see a need to bring the balloon resources to the delivery room because it's easy for us to transfer. However, each center is going to be very different. How far is your heart center from your maternal hospital? And that's what determines where you bring your resources. Lastly, I would say that if there is a reverse differential cyanosis, be aware that some of these, about 10% of these d-TGA would have significant pulmonary hypertension, which will require treatment with oxygen and INO. There are publications that kind of guide. I think this is just a summary of what to look for in the first column, what to look for prenatally, what resources we are going to need it, and what delivery room recommendation could be applicable to many of the centers. All right. Lastly, I want to jump into outcomes. Does prenatal diagnosis improve the outcomes? Yes. There are multiple publications that would indicate that the group that had prenatal detection as compared to those d-TGA that were postnatally detected, the prenatal group has faster admission to ICU, had earlier initiation of PGE, and earlier age at the arterial switch operation because of the awareness. We were already aware of d-TGA, so we planned everything. But ultimately, that's not what matters. What matters is the likelihood of survival. This study, I believe this was from Canada group that they compared. The red is the prenatal group, the blue is the postnatal group, showing the difference in survival and improving survival in the prenatal testing. When I sit down with families to discuss the d-TGA, I want to kind of give overall what to expect for their baby. And I think that this particular paper published in JACC in 2023 did a good job of summarizing what to expect. This is a large N of about 1,700. It's more population study kind of a thing. We would say that overall mortality is low. 3%, 3.2% at 10 years mortality. Although this is a European study, I would say that in US, we are seeing similar anticipated outcome with d-TGA of survival of 3% mortality over 10 years. There is a low hospital resource utilization, meaning once it's done, they are able to stay home and don't need a heavy resource utilization as compared to, for example, our single ventricle population. operation. There is a high risk of reintervention. About 11% of them will need some intervention by the time they're 10 years old, most of them related to either branch pulmonary artery stenosis after arterial switch operation, or second most common would be intervention for that neo-aortic valve, because originally it was pulmonary valve, then we ask it to be neo-aortic valve, and then it has complication that needs to be addressed. Risk factor for mortality and reintervention. For mortality, what matters is that if the babies ended up needing renal support, like dialysis after the surgery, ECMO after the surgery, low birth weight, and comorbidities, those are the risk factors for mortality. And then few other things that age at arterial switch operation, if performed in first 3 of life, there's advantage of that. So earlier repair is definitely more important. Septostomy did not affect the mortality. So it doesn't matter as long as you do the septostomy. Overall, long-term surgical mortality is the same. And then those were short term, but let's look at the long-term outcomes. This particular study looked at about 1,100 patients and then followed them for about 9 years. And then what they found was that about 9% of patients met outcome, and those outcomes were death, transplant, or other outcomes. So overall, when you look at long term, look at these patients range, by the time they finish their study, they're 40 years to 60 years old. So this is truly a really good data set for long-term outcome. There are patients who experience sudden death, but those sudden deaths are more if there is atrial arrhythmia, if the patient has pacemaker, and few other things. The important thing about this study is that many of these patients include the earlier cohort when we did not do arterial switch operation and we did the mustard and sending. So I would think that the outcome that we could achieve for a baby born in 2025 would be better as compared to this study, because this is more historic cohort. And then another study looking at the long-term outcome. I think this particular study showed the differences between the TGA with intact ventricular septum, the solid line. They have the best outcome, followed by TGA with VSD, and followed by TGA with aortic arch obstruction. So this is important when we are sitting down with the parent, that that's why we want to look for VSD and aortic arch obstruction, because it matters for long-term outcome when it comes to freedom from mortality or freedom from reintervention. The intact ventricular septum group outperforms the two other groups. I think we have already reviewed this point. So I would come to the take-home points that prenatal detection of d-TGA does improve outcome. So I am happy that we are improving the prenatal detection. We're not there yet to detect all 100% of d-TGA, but we are reaching like a 60-70% prenatal detection rate in Northern America. Fetal echo findings can detect atrial restriction with high specificity. So when those findings are present, they are helpful, but poor sensitivity, meaning that if you don't see those high risks, then you still have to be ready for balloon-atrial septostomy. And then center-specific workflow can improve the delivery room stabilization, and overall d-TGA with intact septum have better outcomes. That's all I have, and I'm open to questions.
Oh, thank you so much. This is so good that I think I've learned everything I need to know about CcTGA. We have a question here. Oh no, that's an old question. Now I'm interested in what you said about be prepared for balloon-atrial septostomy for all. That's the word.
Can specify a little bit more. I say it all because the sensitivity of those fetal cardiac markers for restrictive atrial septum is low. So it can look so good that, oh, look at this beautiful atrial septum. It's open at 34 weeks. And then the baby will come out and be very blue. So because of the low sensitivity, that's why it is important to be prepared. Now, baby can come out and prove us that, oh, I don't need a balloon atrial septostomy. So our criteria for balloon atrial septostomy, at least at Lurie, are mainly guided by the postnatal oxygen saturation. So our first one is postnatal oxygen saturation at about 20 minutes or 30 minutes of life, not right away, because you start very low and you can't decide by like 5 minutes of life, right? Like you have to give it transition time. So that's our first indication. If the pulse ox is good, above 75 we consider good. Like above 75, we're happy with it. But then what are we needing to give to the baby to achieve that 75? If we are intubated, that's not good. So then we want to achieve above 75 without respiratory support. That's our goal. So our second marker that makes us think that this baby needs better mixing is that if we are needing too much respiratory support to achieve above 75. And then the third thing is our blood gas, because very low PaO2. And if we think that we are not going to be able to sustain this physiology for 3 days until baby can go to the surgery, then we should do the balloon atrial septostomy. And then our fourth one is echo. When we do echo, a hole that is less than 3 millimeter make us worry. So if it's a very small atrial septal communication, then even though in the moment thing may look good, we don't want things deteriorating in middle of night. So we have this stage approach of arriving to a conclusion that we need balloon atrial septostomy, but our patients at least need to show some sign that, okay, I need balloon, but it's like we need to be prepared and we need to let the baby tell us whether we need the balloon atrial septostomy. Does that make sense? I think that's why.
Yeah. So be prepared. That's the word.
Be prepared. Be prepared. Yep.
Okay. So I mean, to summarize, this is very important what you said. Add in 20, so that decent word, even with an right. And the other thing you said that when you echo for 3 about the gradient across, do you go means or anything like that? Mean gradient across, or just the size?
Size, we don't like to see any mean actually. So when you are seeing a Doppler pattern that is generating a mean, even if like mean of 1 would mean that there is restriction. So by definition, unrestricted atrial septal communication should not be able to generate any Doppler pattern that I could measure. It should be freely flowing. When I put color, it's a low Nyquist and no turbulence. And then when I put the Doppler, you can see in and out of flow, very low velocity, no mean gradient.
But some would say, okay, take the baby, start prostaglandin, let's wait, let's see. And then if a mean of 1 or 2, maybe things will improve. I mean, that's a dilemma. I mean, you're trying to be perfect. So you say, okay, we're going to do it, we're going to do it. But in real life, sometimes people don't do the septostomy immediately. I mean, they wait.
Yeah.
And also, sorry.
No, I was going to say that we are at about 50% balloon atrial septostomy rate at Lurie by following this guideline, but not all are emergent. We have done one that is a bit later. So I would say that about 2/3 to a little bit more than that are emergent, but there are babies that we have decided a little bit later that, okay, the surgical date is not until 3 days later, and although initial first hour saturations were good, we are seeing fluctuation that are making us uncomfortable. So this, if that
I
answers
understand. I understand, but I want to make it for the audience. You are worried about the brain, the oxygen to the brain, right? So, but it's already affected antenatally. You don't want to add to it, right? You want to add,
Yes.
you don't want to add. So this is very important and a very respected point that what we see in real life is, oh, wait, just wait. No, you're trying to say, don't wait because we're already late. after delivery. Now, antenatally, sorry, we have a question regarding septostomy, regarding what do you do it to perform at bedside? Do you do it under echo guidance, fluoroscopy, or both?
We do under echo guidance at bedside. So we will do it in our ICU. We would only take baby to cath lab if the baby's weight is too small, because the risk or complication rate is higher, and our cath team feels more that they have more resources around them and more things, more instruments in the cath lab. So if a baby is less than 2.2 kilo, we will go to cath lab. But we haven't gone to cath lab in a while. So usually we are able to do that at bedside under echo guidance.
The same person is asking, if you have interrupted IVC, would you not do balloon septostomy? What will be your access?
Yeah, the interrupted IVC is a problem, because you could think about the IJ axis, but the alignment, like if you think about the catheter from the IVC has a natural pathway to go across the foramen ovale, and when you pull it, it is safe to do that. The IJ is very short course from the balloon to the neck, and that is a problem. And we would sometimes feel like, how big is the baby, and then if we can do early arterial switch operation, if we could. But if the baby is super blue, if baby's pulse ox is 40%, then we have to take the risk of other ways of doing balloneal septostomy. If that
From the neck, you mean from the neck? Okay. Now going back, because what you said something very important, the outcome in balloon I think that was studies shown that it has improved outcome, correct? Like in hypoplast, we're not sure, right? In hypoplast, the outcome, if antenatal improved the outcome, not debatable. But in this disease, I mean, the success rate was quite high.
Yes. And I think it just speaks about how d-TGA is such a lesion that it is highly complex in first few hours. And if you manage that baby really well for first few hours, and then if baby needs balloon, you do balloon, long-term outcomes are superb. So hypoplast, because long-term, like even though you do everything perfectly, it's still not like, you don't reach to 97% survival, right? d-TGA is one that, as long as you manage it well, the long-term outcomes are really good. So I think this particular lesion does well, significantly better when we know prenatally.
I think we have to add to the significant good outcome if it is d-TGA with normal genome nowadays, right?
Yes.
Because we don't know. Now, going back to what you said about the restriction of the foramen ovale, there are lots of studies, and I just want you to recap, to go home, what will an echocardiographer look for when they are scanning the foramen ovale? And I think you should always add pulmonary veins to it.
Yes. Absolutely.
So what would you find? Like you said that hypermobile septum, the risk factors, the size. Could you please, because I think this is a very important take-home message for colleagues who are working on their own.
Yes, absolutely. So here is the slide that I have that summarizes the findings of the atrial septum. So first do the 2D. Look at the movement of the atrial septum and see if it is a hypermobile septum. Definition of hypermobile would be it will be going in both atria, in right and left. It like flip-flopping between two. Then stop the image and measure the size of the foramen ovale and compare to the total septal length. And then if this is less than 1/3, that's a problem. Then you will put a color and then see the flow. Ideally, you want to see a flow that just goes from the right atrium to the left atrium, and you don't want to see flow reversal. So you don't want to see bidirectional flow. You only want to see the right atrium to the left atrium, because the placental blood is coming here in the right atrium and it should go to left atrium. And then you look at the angle of the flap of foramen as compared to the atrial septal level. And less than 30 is more called fixed flap. and fixed flap is a problem. So those were my atrial septal recommendation. And here are three things that are ductus arteriosus findings: a small ductus arteriosus, restrictive flow with pulsatility index less than 1.8, and then reverse or bidirectional flow across the ductus arteriosus. So those are the three ductus arteriosus finding. And the pulmonary vein peak systolic velocity is the my next marker. So atrial septum, ductus arteriosus, pulmonary vein. And then lastly, how do you interpret here is a summary of that meta-analysis paper that put the atrial septum findings, ductus finding, and then pulmonary vein finding.
So this is very, very, very important. Thank you so much. I think
You're welcome.
this is very important when we're doing echo to look at the septum and the thickness, because I remember one of the cases postnatally when I was at SickKids needed septectomy, not just septostomy, septectomy. It was very thick. And they've done it at the delivery room because antenatally it was the pulmonary veins showed some sort of ratios, the reversal, the flow. Everybody knew that this baby is not going to make it without having this immediate septectomy, not other than septostomy. So the septum was quite rigid, which is very important. Also, another very important point to learn from your talk today is what you said about pulmonary hypertension, because we know that d-TGAs have increased flow in the pulmonary vascular bed or pressures. And you've explained it by saying that part of it is due to the parallel circulation. Is this proven, or is just a conclusion?
That was hypothesized from the fetal, like a physiology, like why these babies have more. Sorry, I'm just going to go to that slide where I was explaining that in a normal four-chamber anatomy, the ductus arteriosus would see more blue blood, less oxygenated blood, because there's a preferentially streaming of the oxygen-rich blood to the left side, right? So the right side gets less oxygen. The duct would see less oxygen, and duct is widely open. But in PDA, the duct is now seeing the higher oxygen because it's getting fed by the pulmonary artery here. And that's what can cause premature ductal constriction. Otherwise, also another proof is that it is common to have small duct in d-TGA. Usually the duct is bigger than pulmonary artery, but many d-TGA babies would have duct that is smaller than the pulmonary artery, indicating that it could be getting premature ductal constriction and then causing increased pulmonary blood volume and increased return. Probably this increased return is what gives us higher peak systolic velocity in pulmonary vein, and then ultimately restrictive foramen ovale because the LA pressure is high. So I think that I find it very fascinating why d-TGA babies are at higher risk for pulmonary hypertension, because in utero, their pulmonary vascular bed have seen more blood supply than what they should.
Yeah, and postnatally, if you do the prostene, you do the septectomy, you do everything, and still baby is not getting better because of the mixing issues
Yes.
in the lungs. Another teaching point they said about the unidirectional flow across the foramen ovale. You said it has to be one way from right to left. But to tell you the truth, sometimes you see a little bit of in the backflow. So is it systole or diastole? So you have to measure it. Where are we saying that's only in normal? I mean, not in TGA. Sometimes you see a flow which is going backwards. So I think you have to time it cycle or what?
We could do the pulse wave Doppler across the atrial septum, and then a true bidirectional would have like equal time spent forward and reverse or bidirectional. You are right. Even in the normal anatomy, you might see a very brief flow reversal in at the foramen ovale, but it is really short lived. Most of the blood is still going from the right atrium to the left atrium. And it's because there is so much systemic vascular return coming to the right atrium because placenta is feeding into it. But the only thing that is coming to the left atrium is that 10%, 20% blood that is going to the lung while lungs are still closed. And because of that difference in what comes back to the left atrium is so small as compared to what comes back to the right atrium is much more volume. That's why most of the blood is going from right to left in normal cardiac anatomy.
Thank you so much. Let's move to the next talk, our last but not least. This is Stephanie Samples, and she's going to talk about connected chapter predict of prenatal care. And so much, I think we've discussed part of it, but you're going to give us the summary and the directions of the outcomes, please. Thank you, Stephanie. Thank you for waiting.
Oh, no, thank you for having us. This is wonderful. All right. So just briefly today, we're going to go through some of the anatomic findings of CcTGA because there obviously are some differences compared to the great review of d-TGA that you just heard from Dr. Patel, and then do a brief review of some of the fetal echo presentations of CcTGA, and then really spend some time focusing on how those fetal echo findings relate to the postnatal outcomes, because this is what is the basis for how we're counseling our patients and how we're prepping them for delivery. So again, just a brief review. When we look at CcTGA, we have atrioventricular as well as ventriculo-arterial discordance. So this is different than d-TGA. So we have a right atrium, which connects to a morphologic left ventricle, which then gives rise to the pulmonary artery. And then a left atrium connected to a morphologic right ventricle, which gives rise to the aorta. This is a fairly rare type of congenital heart disease. It actually represents less than 1% of all congenital heart disease. So it's only got a prevalence of about 0.02 to 0.03 per 1,000 live births. So not something that we're going to see very frequently. There are a lot of different cardiac anatomic associations with CcTGA. So we can see VSDs, we can see pulmonary outflow tract obstruction. There could be tricuspid valve abnormalities, abnormal cardiac positions such as dextrocardia or mesocardia, and aortic arch anomalies. We can also have rhythm abnormalities. Most commonly, we all think of AV block, but in rare cases, we can also see episodes of SVT as well. So it was important to keep that in mind. So when we think about our associated lesions now, this is what's going to form the basis for our fetal echo checklist. So in CcTGA, it is so important to start with your situs evaluation to know, because we can have situs anomalies of the heart location, but then we also want to go through the atrial, ventricular, and arterial situs to know how all of our connections are. Again, that cardiac position is so important, and we've got some good examples of that. And then we're looking for all of our associated cardiac lesions, the ventricular septum, the outflow tracts, the AV valves, particularly that tricuspid valve structure and function, and then the aortic arch, and obviously a good assessment of the fetal heart rate and rhythm. And these are things that you need to do repeatedly throughout gestation because things can change as we go along, and we'll talk more about that later. So just a few echo examples. Again, you want to start with a good situs sweep. In our lab, use the in a longitudinal rate and rotate degrees. And so we kind of is into this in this prejudice. This is now the left side and this is the right side. So we can see that the apex is pointing towards the left side of the screen. Focusing more on the actual sweep through the heart. Again, we can see that apex is on the left side of the screen. And if you watch closely, you can see that the first vessel that comes out is actually bifurcating, meaning that our first vessel is going to be our pulmonary artery. You can also notice that the ventricular morphology appears a little bit unusual, and you can see the tricuspid valve offset, which we will show a little bit more detail. Again, we can have cardiac position abnormalities. So when we do our situs sweep again, in this particular patient, as we come down, you'll notice now the heart is quite midline and the apex is going almost completely anteriorly. So this is a patient with mesocardia who has CcTGA. And again, when we sweep through the heart itself, you can really appreciate that that first vessel that comes out of the center of the heart is now bifurcating as it's a pulmonary artery. So I think when we have an abnormal cardiac position in the setting of CcTGA, it can be really challenging to try and keep yourself oriented as we're moving around to scan as the baby moves during our scan. So there's a few sort of tricks that I think help out once you have established your situs. In this baby with mesocardia, you can really clearly see that the pulmonary veins are draining here to the left atrium, which again is now connecting to the morphologic right ventricle. So that can help reorient you as you go along during your scan, if you just look for where are those pulmonary veins draining. The other thing we can look at is that placement of the tricuspid valve. As we all know, the tricuspid valve, even when normal, has a slight apical offset compared to the mitral valve. So looking at where that AV valve is more apically offset can again help orient you to which is the left side of the heart and the right side of the heart, no matter where your cardiac position is, and can kind of help sort of keep you straight as the baby moves around. This is a fetus who had normal situs on the left-hand side of the screen. On the right side of the screen, this is a fetus with mesocardia. And so looking at where that tricuspid valve is more apically offset, again, can kind of help keep you oriented to which side of the heart that you're looking at as you're going through your evaluation. Once we have established our situs and we can recognize that we're dealing with CcTGA, again, we want to do a good sweep through the heart. And again, as you can see, that first vessel that comes out of the heart is going to be that pulmonary artery that bifurcates, and then you're going to get more interiorly that aorta coming out. We can do the same thing with color compare here, showing that the aorta comes out more interiorly. Kind of similar to d-TGA, you're going to get an abnormal 3-vessel view. And that's because the arteries are coming out in parallel, they're not crossing, so you won't see both at the same time. You'll actually pan through the pulmonary artery first and then the aorta, so you're never really going to get both of those in a single view in your typical 3-vessel view, which is often, again, the indicator for why they're sent to us for this particular lesion. You can really look at, again, the offset of your tricuspid valve, and depending on the orientation, you can get a nice evaluation for VSTs and your systemic veins as well. When we do the same sort of view, again, with a patient with mesocardia, we can see the same orientation where the PA comes out first and then the aorta. And again, you're looking at all your other findings to kind of help keep yourself oriented to this is the left side and this is the right side, because in this case, this is mesocardia. The heart is directly in the center of the chest. And so it can become really challenging to do these evaluations as the baby moves around. But you can see that other than the location of the heart in the chest, these images look very similar to the previous ones, because there aren't any significant associated abnormalities in these fetuses. Now, when we do a 3-vessel view, when there are abnormalities in these 2 fetuses, one with severe Epstein's here on the left side of the screen and one with double outlet right ventricle, you notice that as the aorta comes out, it's a lot more challenging to see. And that's because we actually, in both of these fetuses, had aortic arch hypoplasia. So as it comes out, the aorta gets very small and very difficult to see in the 3-vessel view, because it's so much smaller than the PA, and it's going to require some additional investigation. When we look at our arches in a more typical sagittal plane, again, they sort of sit right on top of each other. So when you get your view, you can actually see aortic arch and ductal arch sort of sitting right on top of each other, with both 2D and then with color flow. You can notice these 2 different color flow patterns, and that's because you have aortic arch sort of sitting on top of the pulmonary artery, because our great arteries are running in parallel. So you're not going to get a typical arch view. And again, when we do the same view in a patient with coarctation, we do, however, we are able to see that the arch narrows down and has this continuous flow. So this is, again, a patient with severe Epstein's who also has a coarctation of the aorta. So we can see those same subtle findings as we would look for in other fetuses, just that the arch is in a slightly different orientation. Finally, as we look for other associated anomalies, we're going to look for VSDs. Paramembranous VSDs are very common, so we can look for these here under the outflows, and you're going to look for that bidirectional shunting, which you can see on this particular patient. You do want to do a good evaluation of the entire ventricular septum, though you'll see as we move forward that membranous VSDs are a little bit more common than other types of VSDs. And finally, as we look at the AV valves, this is a patient with a very severe form of Epstein's in the setting of CcTGA. And so by 2D, again, you can see this is the level of the tricuspid valve annulus, but our valve leaflets are actually quite tacked down almost towards the apex of the right ventricle, the morphologic right ventricle. And so it's a very abnormal appearing valve. And then when we add color flow and as we pan through the valve, you can see that there's very significant tricuspid regurgitation in this fetus. And this was at a relatively early gestational age. So this is going to be an important finding to look at so that you can, again, help risk stratify your patients. So now that we've done our fetal echo and we're going to have to go counsel our patient, how do we relate these fetal echo findings to what their potential outcomes may be? So I'm going to spend the rest of the time really diving deep into this article from 2023 in the AHA journal. This was from the Fetal Heart Society Research Collaborative. And so they looked at CcTGA, the Fetal Diagnosis Associations and Postnatal Outcome. I really like this paper because it's really the largest study assessing fetuses with CcTGA. This is a very rare disease. So this was a large multi-center study. It has like such a great treasure trove of information that I think we can all use when we see these patients in our practice. So just a little background on the paper. This was 20 cardiology programs in the US and Canada. And they did look retrospectively at all fetuses with a prenatal diagnosis of CcTGA between 2004 and mid 2020. So this was quite a wide array of years. They did exclude any anatomic findings that the centers felt were certain to preclude a biventricular repair. So if the center was already counseling the patient that you're definitely needing single ventricle repair, they excluded those patients from this analysis. And you'll see why that's important later. Their primary outcome that they looked at was any continued pregnancies who had death either fetally or postnatally or transplant by 1 year of age. But you'll see they really did a wonderful job of looking at a lot of additional sub-analysis. Just a little breakdown of the number of patients that they had. So they started out with 205 patients. They obviously lost some to follow-up because this was all retrospective. There were some terminated pregnancies. Fetal death occurred in 1.5% of cases, and then the remaining 80% or so were live born. Again, there was a little more attrition because you lost some to follow-up before 1 year of age, which was what they were looking for. And then past that, you had those who had a heart transplant who died or were otherwise alive with other interventions by 1 year of age. All right, so then they looked at cardiac pathologies on the first fetal echo. So this is really just reporting what they saw on the first fetal echo. And as you can see, this is quite a large table because there are a lot of different associations and combinations of associations that we can see in CcTGA. So I just want to point out sort of some of the more significant associations. So obviously, we've already talked about heart position. While most patients had levocardia, there is a not insignificant amount of patients, about 19% with dextrocardia, and about another 14% with mesocardia. So that's why I stress so much establishing that situs when you start your fetal echo. The next thing that we saw quite a bit, about 68% had VSDs. You can see they then broke it down into type of VSD, with membranous really being the most common, and then inlet after that, and then fewer percentages of muscular, doubly committed, malalignment, and then sort of a not determined type of VSD morphology. Pulmonary outflow tract obstruction, which they included pulmonary atresia in this category, occurred in about 38% of patients. So again, a not insignificant amount. And tricuspid valve structural anomalies occurred in almost 20% of patients. And we'll talk about why this may actually be higher than we think as we get further. Importantly, when we looked at the degree of tricuspid valve regurgitation, about 26% had a significant degree of tricuspid valve regurgitation. We also had about 10 to 11% who had some degree of aortic arch hypoplasia and coarctation. So this really gives you an idea of how many associated lesions you can see with CcTGA. And again, there are a lot more things on this list, which are just seeing a little less frequency. But so I think this is a good reference when you're trying to figure out, is this something that has been seen before with CcTGA when we're looking at these complex patients? So they did a lot of analysis of their data. The first thing they looked at was those who had a diagnosis of fetal heart block. So they had 23 patients in their cohort that were diagnosed with fetal heart block. That's about 11% of their cohort. 22 were actually on their initial fetal echo, and 1 was on their follow-up fetal echo. The average gestational age was at about 25 weeks with an interquartile range of 23 to 28 weeks. I think it's really important to understand that actually isolated CcTGA was significantly more likely to have AV block than those who had just other associated intracardiac defects. That's an odds ratio of 2.8. And interestingly, because I think this is a little different than what we think about in otherwise normal hearts, of the 15 fetuses who had situs inversus, none of those had AV block, and also none of those with heterotaxy had AV block. So this may seem a little counterintuitive because I think we're so used to looking at those with heterotaxy in particular having a higher degree of rhythm abnormalities and AV block. It's not the case in CcTGA. This is a very busy sort of table, but I just really want to focus on two things here. They were looking at those fetuses which had serial fetal echocardiograms. And when they did that, they saw a fairly significant amount of both functional changes and anatomic or diagnostic changes on their serial fetal echoes. So there was about almost 40% of those with serial fetal echoes had at least one change noted on those subsequent echoes. And then when we looked at postnatal echoes, again, another almost 40% had more diagnostic changes again. So this is why seeing CcTGA patients repeatedly throughout gestation is very, very important because there may be functional changes, and this can be things like increased tricuspid valve regurgitation or changes in heart function, or there can be anatomic changes where we again, pick up on other of these associated lesions and are better prepared for postnatal interventions in these patients. So serial evaluation is really critical. So this table, again, now we're looking at the postnatal clinical outcomes on the fetuses who were prenatally diagnosed. So I think it's important to know that like 83% of these patients went to the NICU, which I think would not surprise any of us. They have a lot of associated lesions. They're going to need a higher level of care. Almost 50% had some type of intervention before a year of life. About almost 30% had postnatal heart block, and that's divided sort of about 40-60 of those who were prenatally diagnosed with heart block and those who were postnatally diagnosed with heart block. And so it's important to remember AV block can continue to develop as we go through not only gestation, but also in postnatal life. And so that continues to be a risk factor. In their group with postnatal AV block diagnosis, about 8 of those were spontaneous at a median of 30 months. So can happen anytime during childhood. 18 of those were associated, 18 others were associated with a procedure. So as we all know, there are some risk for block with some of the procedures that are performed on these patients. So it's not all their innate risk factor. So the next thing I would say is that obviously, as you would expect for anyone with heart block, there was a rather high degree of need for pacemaker. About 75% of patients had pacemakers. And then death at any time point in the follow-up was about 10 to 11% of patients. And so it's not an insignificant degree of death at any time point. And then lastly, the type of repair they had at last follow-up, you can see is quite variable. There are those who had anatomic repairs, had physiologic repairs, had single ventricle, 1.5 ventricle, PA bands. And then again, there was that smaller percentage, about a little less than 40% who were unrepaired. And then there was a small percentage that were lost to follow-up postnatally. I think this is what was most astonishing to me is that 15% of their patients had single ventricle palliation. And this is where I take you back to their initial exclusion criteria, which was they excluded anyone they felt was certain to need single ventricle palliation, which means another 15% of patients that were thought to be biventricular or at least 1.5 ventricular repair candidates on their initial fetal echo were subsequently deemed to be single ventricle candidates. So that is something that I think really needs to sort of inform our counseling, is that there can still be some risk for need for single ventricle palliation in the long term. So now that we Now let's look at the sort of association of the hemodynamic and anatomic factors with single ventricle repair, especially. So they did this really lovely sort of deep dive sub-analysis in these patients. And so what they found is that when they looked at the associated lesions and hemodynamics, and this is on the first fetal echo, on those who eventually had a single ventricle outcome, those things that affected this were pulmonary atresia, was tricuspid valve straddling, was any degree of mitral regurgitation, the presence of an AV canal defect, the presence of dextrocardia, or the presence of heterotaxy or a VSD. So a lot of different things can become associated with the eventual need for single ventricle palliation. So when we see any patients with any of these findings on their first fetal echo, we really need to keep in the back of our mind, they may still eventually be a single ventricle palliation candidate, even if the two ventricles, look promising on that first fetal echo. All right, so then they did a further breakdown looking at, again, the factors that are associated with that primary outcome, which was death, either fetally or postnatally, and then the need for heart transplant. And again, they're referring back to that initial fetal echo. And so when they did this analysis, they saw that the factors that were more strongly associated with death or transplant were the presence of pulmonary atresia, mild or greater tricuspid regurgitation, mild or greater mitral valve regurgitation, any aortic outflow tract obstruction, and then any fetal AV block. There are other things like the presence of SVT and decreased LV function, mitral valve abnormalities, and even RV function, which came out to significance, but they had really wide confidence intervals, which the authors of the paper felt were due to the very limited patients. Most of those couple of categories, they only had 2 or 3 patients, for instance, with SVT, and 2 of the 3 patients with SVT died in the first year. So this led to a really wide confidence interval. And so while it was statistically significant, they weren't really clear on how clinically significant it was going to be. And then when we looked at factors on serial fetal echocardiograms that would be associated with their primary outcome of death or transplant, what they found was any worsening effusions, any increased aortic outflow tract obstruction, or the composite of worsening TR, RV function, and pericardial effusion were all strongly associated with eventual death or transplant by 1 year of age. And again, I told you this is a very dense paper, so they did a lot of sub-analysis. So then they looked at the factors associated from that first fetal echo to death and transplant, where they now sort of excluded the people who had fetal death, who were lost to follow-up. And so you're only getting those who truly made it to postnatal life. And they found a few subtle differences when they excluded those patients. Notably, they didn't find any association with other prenatal clinical factors with their primary outcome. So for instance, the gestational age at diagnosis, any other extracardiac anomalies or growth restriction, interestingly, were not associated with their outcome of death or transplant by 1 year of life. So now when they did this breakdown, again, pulmonary atresia is still significant. Aortic outflow tract obstruction is still significant. However, now mild or greater TR is no longer has a significant, statistically significant result, as the same with mild or greater mitral valve regurgitation. So when we excluded those patients with fetal demise, so we got slightly different changes. Again, this is a continuation of that same table where they found now dextrocardia is definitely now associated with that primary outcome. Again, our fetal SVT, remembering that we had a very small number of patients, and then also any other fetal arrhythmia. And again, same on our serial fetal echoes, that increased aortic outflow tract obstruction or that composite of worsening TR, RV function, and effusion. Again, at this point, when we excluded those with fetal demise, now fetal heart block stops having a statistically significant association, which is interesting and may have to do with the number of patients in this cohort who actually had fetal demise when they had AV block. Again, that impact of prenatal and postnatal demographic or clinical factors on death transplant were assessed, but they didn't find any other associated factors. Also, interestingly, intervention before 1 year of age and the type of intervention were not associated with death or transplant by 1 year of age. So seems to matter less essentially exactly what we do with them after birth, and has more to do with all of these anatomic and functional factors. So again, I know this was a very dense article, so I just want to really reiterate a few of what I think are the important take-home points from this study. Genetic abnormalities were relatively uncommon in this patient population, so only about 6%, with the sort of asterisk that only about 40% of the patients had prenatal genetic testing, and this included karyotype, FISH, and microarray, which you've heard all about from Dr. Jones already today. And so the authors really theorized that maybe more extensive testing, such as with a whole exome, might increase this number in the future, and so we really need to do some additional evaluation of this. They also noted, interestingly, that the family history of congenital heart disease in this cohort was about 11%, which again might point towards some genetic basis as well, which you heard about from Dr. Jones this morning. AV block occurred in about 11% of the patients fetally. And again, this was most commonly observed in isolated CcTGA, and no one with situs inversus or heterotaxy had fetal AV block. It was a very important risk factor for fetal demise. 11% of the patients with AV block had fetal demise. So again, this is a really important risk factor for us. It's also important to remember it's often not diagnosed until the late second or early third trimester scan. And so if you're seeing them very early in gestation, you need to continue following them serially because you might see them more commonly as they get a little later into pregnancy. And again, most of these patients did need a pacemaker postnatally. About 40% of patients had some type of anatomic or functional cardiac progression on serial fetal echoes. So I can't stress enough that following these patients serially is very, very important. Particularly progressive pulmonary outflow obstruction and tricuspid regurgitation were most common. And this may be because that natural tricuspid valve offset tends to increase a little bit throughout gestation. So abnormal offset may not become really apparent until a later gestational age. So you need to keep evaluating not just the degree of TR, but also the structure of the tricuspid valve as well. And always remember too that all of this progression can continue after birth as well, again, particularly for tricuspid regurgitation, pulmonary outflow tract obstruction, and RV dysfunction. As I sort of pointed out already, but I want to drive it home, this study excluded patients that they were thought to already be single ventricle palliation candidates because they had significant ventricular hypoplasia, but despite that, 15% of their cohort still needed single ventricle palliation. So this is not a small risk factor in these patient populations. Again, more associated with pulmonary atresia, tricuspid valve straddling, associated AV canal defects, dextrocardia, heterotaxy, and any mitral regurgitation. Interestingly, if we qualitatively thought the RV was hypoplastic, that's not actually associated with if they needed single ventricle palliation, but always something to keep in the back of your mind as you're evaluating all of these structures on these serial fetal echocardiograms. And finally, while the risk for fetal demise in this cohort was relatively low at only 1.5%, that risk of postnatal death and transport was somewhere just south of 7%. So, still something to counsel our patients on, and especially when you're looking at things like aortic outflow tract obstruction and worsening tricuspid regurgitation, that really can contribute to these worse outcomes, while something like dextrocardia can also be associated with worse postnatal outcomes as well. So again, you may want to counsel some of those patients a little bit differently than you would those without these specific findings. Thank you.
Thank you so much, Stephanie. It's a really important topic and not easy to diagnose. I just wanted to from you now, while you're scanning, okay, how would you come to the diagnosis with the first the valve? How process?
I think we start with the situs. And so as we do that initial situs sweep, in an ideal setting, we are going to sweep all the way through the cardiac structures. So I am not only paying attention to where the cardiac apex is, I'm paying attention to sort of, where the AV valves are, which one is apically offset, and then how those great vessels are coming out. I think I stress the outflow tracts because I think that becomes the most apparent thing to a lot of people, that the first vessel out bifurcates. which stands out to a lot of people. That's a lot of times how our OB and MFM colleagues pick this lesion out, because it takes a little more sort of focus to really notice those subtleties on the AV valves, because again, the tricuspid valve may not be very significantly offset, so it may not be quite as apparent on those initial sweeps. So I think a lot of times the relative relation of those outflow tracts may be your first big indicator that something seems off and I need to pay a little more attention to how all of these structures are related to each other.
So this is very important, that the great vessels, but they could say, oh, this is the d-TGA. So the trick is that you have to do a proper 4-chamber view, and then you get
Yes.
the offset. Okay, we got the great vessels, but the second question would be, okay, where are they coming from? And as you
Yes.
said, that the 3-vessel view, you've also said very, very important that the 3-vessel view, you will not get the 2 great arteries at the SVC in the same plane as we do. This is another important factor. I wouldn't go into a topic called ventricular inversion, because this is sort of ventricular inversion, but Dr. Silverman left us already. Now, we also said very important about the heart block in antenatal. We know that all CcTGA or double disco hearts, they are at risk of heart blocks. We always come to them later on. But only 11% happened antenatally, which is interesting.
Yes.
Any
Yes.
explanation for that?
No, I think it's just that sort of idea of it can happen at any time. And so some of it will happen antenatally and some of it will happen at other times. So I think in my mind, that risk factor is one that is always there and is always in the back of my mind that I'm always looking for, because it's not a risk factor in this lesion that we ever leave behind, unfortunately. While everything else, I feel like anatomically, we see what's happening very early on, that risk of AV block just is always there in the background, just sort of lurking and waiting, to pop up.
Yeah, and very, very important. Also, you've said something important about the outflow tracts. Now, which outflow tract you have to worry more about, the aorta or the pulmonary, and why?
I actually think they're both very important, mostly because, as you saw in the paper, there's really a lot of associations with poor outcomes with either outflow tract being obstructed. So I think they both play a critical role. I guess you could say because pulmonary outflow tract obstruction is probably a little more common than aortic outflow tract obstruction, you could, argue that it might be more important, but I think they both play into poor outcomes if they're there. And I think also too, there's so many other factors, like for instance, if the aortic outflow tract obstruction is associated with a lot of tricuspid valve regurgitation, that's now a very high risk patient. And so I think it's a little more about also what are the other associated lesions within that heart, rather than just one particular outflow tract. But I honestly think they're both very, very important because they can both be associated with poor outcomes.
Although the risk factor was the aorta, not the pulmonary, out of in the paper. What
The
they got
pulmonary atresia had some risk factor as well. So not so much obstruction, but pulmonary atresia.
Great. Sheetal and Edward, can you share, because we're closing very soon. Sheetal, do you, I mean, from your vast experience, what would be the echo advice to pick up the double disco hearts? I always call them double disco because so what would be when you're scanning? What is the advice? And go like as Stephanie said, go by 4-chamber outflow tracks and blah blah blah. And I think the axis is very important as a hint. So from your experience, what would be the advice to pick, not to miss?
Right. I think that the CcTGA heart, because there are multiple things that are not appropriate, not normal. I think that once you have the indication that something is wrong with the heart, it is really important to look at the ventricles and see morphologically what is the right ventricle and morphologically what is the left. Now, there are 3 things that helps us with that, and those 3 things are One is the offset of the AV valve, second is how smooth the interventricular septum is, and third is the moderator band. I for the eyes or for a learner, moderator band could be a little bit more easy to detect in fetal life when you see it, but you don't always see it depending on what imaging resolution you have. I think that the attachment of the AV valve, because mitral valve is all supposed to attach to the lateral wall, nothing should go to the septum. If you really focus on where these attachments are going, that could be your like more easier way. And then later gestation, I do think that offset sometimes is like apparent that, okay, this valve is a little bit lower than the other valve. But I find the offset to be a bit challenging in the fetal life because the offset is so minor in a small heart. I think that moderator band and then the attachment of the AV valve are more easier to detect. But I think that if we are looking, you will see it. If you're not looking, you will miss it. So I would say that to my trainees, that your eyes will see what your brain knows. If your brain is not intentionally looking at the ventricular morphology, it would be right there and you will miss it. So your eyes are going to see what your brain knows. So start with intention to, I'm going to figure out if this right-sided ventricle is right ventricle or left ventricle. And if you look for it, you would at least have some criteria which will tell you that, these ventricles are switched or inversed. So I think our brain sets us up for success, and then you look for things. But if you don't intentionally look for that, you might miss it. You might think it's a d-TGA. But I also think that by the time you look at you are supposed to look at systemic venous return and pulmonary venous return, right? So by the time you say like, oh, this systemic and pulmonary venous return is also switched, I think that you would arrive to that conclusion that this is double discordant. Now that I'm latching on that term now.
No, what I'm saying, I think this is important that, we got the transposition, then go back to the ventricles, right?
Mm-hmm.
Because you might be very happy with the transposition, but in fact you're missing ventricular inversion as well. And very, very important also. Ted, what about the genetics of the paper?
Yeah, first I would say what great talks. I feel like I've learned so much over the past hour from Dr. Samples and Dr. Patel. So I appreciate being involved just for that reason alone. I was not surprised by the finding, and I appreciate Dr. Samples' attention to detail about what testing was actually sent, because that's the most important thing here. Both CcTGA and TGA we think of from a genetic etiology perspective as being laterality defects. I think if you think way back when, the more definition from a morphologic perspective, most people would think of TGA as being a conotruncal defect. But what we've realized as we've done more and more genetic testing and understood sort of genetic etiologies is that TGA actually groups more specifically with these other laterality defects. And during my talk, one of the things I showed was this big pie diagram that I kept coming back to that showed that about 25% of congenital heart disease is caused by aneuploidies and by copy number variants. So those would be things that would be captured by a FISH, a karyotype, a microarray. But it just so happens that laterality defects are disproportionately less affected by and less associated with those types of genetic lesions. So if you're a really experienced provider and you think, like CcTGA, TGA, I really don't see a lot of genetic associations or syndromes associated with those, well, you'd be right. So we know that those types of lesions, laterality lesions, are specifically enriched with sequencing variants. So these are changes in single genes that are associated either with left-right patterning in development or associated with like ciliopathy. And so you're not going to interrogate those with a karyotype, a FISH, or a microarray. You're only going to be able to interrogate those with either like dedicated gene panels or with exome or genome sequencing. So I think that's a great addition to sort of what Dr. Samples had mentioned in her talk, was that that study really doesn't capture the likely much higher genetic burden. And that's evidenced by the fact that what was it, like 11% of those patients had family members with genetic disease. That is ripe for testing, and I think that's what we're going to find out more and more, is that as this broad spectrum genetic testing gets used more, we're going to have even more and more insight into what these causes are.
So laterality and family history are important, right? Because in laterality, you get a family history. And I think heterozygous is laterality as well, and celia and all that. So what you said is very, very important. And what Stephanie said, that the genetic outcome proved what you said. It's a laterality rather than anything else. The other thing is that this is done in 22. So nowadays, I think they're going from whole exome to whole genome. I'm not sure.
But, no, you're totally right. It's kind of been more in vogue.
But the cost, very important. People ask about the cost. So let's stick to the microarray. Is cheaper than the rest. And if it is positive, you go. But no, you said it would be negative. It will be negative in laterality. So should we go and with this, the whole exome from day one, if you have CcTGA or laterality problems?
Yeah, I'm so glad you asked that. So one, there's really good data, especially in the NICU world and in the general congenital structural anomalies world, not just congenital heart disease, shows that broad spectrum genetic testing early can actually decrease costs, because you don't spend as much time looking for all of these different answers, and you can actually prevent complications from occurring beforehand if you know about genetic predispositions to complications. So you can shorten the length of a diagnostic journey significantly by starting out with a big test. The second thing is that when you do this stepwise testing, if you start with a genome, oftentimes you can capture all of those things at once. But in the case of someone, for example, with CcTGA, if you did a chromosomal microarray, that's a really low yield test, but it's still expensive for someone with CcTGA. Whereas if you did a genome, you would capture everything that you would have captured with a CMA, but you also would have expanded your yield by looking for the things that actually you were looking for. And so many times, if you do have like a big family history or something like that, you have a prenatal amniocentesis that gets a CMA, and then postnatally you have a second genetic test that gets sent, or sometime later, and you could have really just started and only done one, as opposed to many serial tests. And so that also cuts down on cost too. There are some insurance providers or whoever the payer system is in either the region of the world that you're living in, that are increasingly recognizing that early broad testing is not just economically viable, it can actually be economically advantageous in certain circumstances, and it's getting cheaper and cheaper.
Thank you so much. We've learned quite a lot. Thank you, Dr. Patel, Dr. Jones, and Dr. Samples, for really enriching our evening or morning, wherever you are. And for our audience, thank you again for sticking late. Here in the Middle East, it's about 8:20 p.m. And this is a recorded webinar. And if you want to listen to it again, it's on the YouTube under the Fetal Series, the Fetal Series Congenital Heart Academy. We have 41 episodes so far over the past 3 years, and we have a full syllabus on fetal cardiology. And thank you again, and have a very good